Hmm. Okay, ma'am.
Ah,
Okay, ma'am.
start பண்ணலாம்னா?
Okay, ma'am.
Ah. Good evening, all. So, thank you for joining for this wonderful session. So, I thank Dr. Prithvi sir for joining with us for doing a rapid revision series in pediatrics. It is a great gesture from him for the benefit of students. So, today we will be starting with the first class in the rapid revision in pediatrics. In neonat, first topic will be neonatology, and I thank him once again on behalf of all the students, and I request him to start the session. So, thank you.
Sure. Live ఆరంభించరా? So
Yes,
live started,
yes,
right?
yes, sir, yes, sir.
Okay. So good afternoon to one and all present. As your university exams are nearby, most of the university exams are starting by March or April, and so I planned a short revision course for the important topics that is most likely to be asked in your university theory as well as your viva, and also it should be useful for your practical wise. So today we will be starting with neonatology. Okay. So I will be discussing our top 20 topics which are very crucial for your university exam, both theory and practical. It will be crisp and concise to the point. In your exam, whatever, whether it is a theory as well as practical, if you're going to tell the examiner in a crisp and concise point way, like in flow chart and relevant diagram, that is all that you need to write in your paper, because most of the time examiners will be seeing only to the important point that has been given to the answer key. And if your flow chart and the diagram which you draw for that particular question contain that relevant point, is more than enough to grab maximum marks. So there is no need of writing a essays, paragraph in your theory paper. Just the relevant points to that topic in the form of flow chart and diagram will fetch you more mark rather than writing a paragraph, and it also helps in your time management. So with this following important points, we will start our discussion. So in neonatology, newborn, this is something different from other subjects. Most of the people will be thinking in that way that if I read medicine, with that knowledge, I can write pediatrics. It is, in some extent, it will help you to do that. But there are few topics which is very peculiar to your pediatric, and one of the important topic among them will be your neonatology, because newborn is not that like a adult medicine. So, as a undergraduate, you should be familiar with few terminology that could be asked in your university questions, like in your theory paper as well as in your viva work. So, which must be known in and out. What is neonatal period? So, what is neonatal period? First 28 days of the life. So, let's wait a minute. Okay. So, what is neonatal period? So, this will be the question. There's nothing but the first 28 days of life is your neonatal period. And thus, this neonatal period is divided into two things. One is early neonatal period and late neonatal period, right? Early neonatal period consists of first 7 days of life, 0 to 7 days of life, whereas your late neonatal period would consist of 8 to 28 days of the life. This definition is important because in subsequent slide we will be seeing NMR and perinatal mortality ratio, where this definition would help you to cleanse the important difference between the two of the ratio. So this is neonatal period. What about post-neonatal period? This is nothing. That is your infancy. So it is defined by the period from day 28 of life till 1 year of age. This is known as post-neonatal period. So what is perinatal period? Now perinatal period is defined nothing but so the period which starts in 22 weeks of gestation or the weight of the baby is more than 500 grams. That is considered to be perinatal period till first 7 days of life, right? So another these are the three important definition. Like neonatal period is first 28 days of life after birth. From 28 days to 1 year of life, that will be considered as a post neonatal period. Perinatal period starts from 22 weeks of gestation till first 7 days of life. So next important one that could be asked in your exam was what is live birth versus stillbirth? Live birth is nothing but any product of conception, irrespective of the gestational age or uh, weight of the child, if it shows any sign of life after separation from the mother. That means after you separate the product of conception from the placenta, if it shows any sign of life, what is signs of life? This could be asked in your viva. What are the signs of life which will tell that the child is alive? One is breathing. Another is your heart rate, pulsation of umbilical cord, right? And finally, movement. If anyone among this is present in that product of conception, then it is said to be the child is that product is showing some signs of life. Then that is known as live birth. Whereas stillbirth or fetal stillbirth is nothing but any product of conception that is born without any sign of life after separation from the mother. This is known as stillbirth. Then the terminology, what is term and where in pre-term. So if you are reading OP Guy in the ninth edition, this flowchart, which is the image that I have given in this slide, is the new one, which is not in present in your ninth edition. It is in your 10th edition, which describe what is preterm and what is term. You know, preterm is the term starts the term neonate. The gestation age starts from 37 weeks. So any neonate that is which are born before 37 weeks, this 37 week is the your center. If any neonate is born before 37 weeks, then it is known as preterm, right? And any neonate that is born after 37 weeks, they are known as term baby. So now you see the preterm is further classified as extremely preterm, very preterm, moderate preterm, late preterm. Extremely preterm, see this image. Extremely preterm starts from 22 weeks to 28 weeks. That is extremely preterm. Very preterm starts from 28 weeks, 28 completed weeks to 31 weeks, 6 by 7 days. Whereas moderate preterm starts from 32 completed weeks till 33 weeks, 6 days. Then your late preterm starts from 34 completed weeks till 36 weeks, 6 days. So this timeline you should mug up because this is the recent changes and it may be asked in your exam about preterm. So when you ask about the preterm, you should classify preterm as extremely preterm, very preterm, moderate preterm, late preterm. In early days, in recent before the terminology term baby, we always include 37 weeks till 42 weeks, 42 completed weeks. They and as a whole, this timeline was termed as term baby. But in recent time, it has been found that babies who are born between 37 weeks to 39 weeks 6 days, they have more mortality and morbidity compared to the children who are born after 39 weeks. Hence, ACOG, that is American College of Obstetric and Gynecology, came with this idea that the term has to be now again classified into three things. One is early term, full term, late term. And they have found that any baby who are born during the early term period, that is your 37 weeks to 39 weeks, they have more chance of respiratory distress, more chance of sepsis, more chance of complication rather than those babies who are born after 39 weeks, completed weeks. Hence, any elective C-section, it has been planned, it has been done after 39 weeks only, not before 39 weeks. Hence, this terminology that this is the reason why the terminology of term has been reclassified into early term, full term, and late term. So early term, okay. So early term means any baby that is born between 37 weeks completed weeks till 38 weeks 9 days 6 days, sorry, they are known as early term. Whereas full term comprises of 39 week completed 39 weeks to 41 weeks. Meaning 40 weeks, 40 weeks 6 days. Any baby who are born between 41 to 42 weeks is known as, we consider them as late term, and post term is nothing but 42 weeks. For after any baby that is born after 42 completed weeks, they 42-week completed weeks, they are known as post term, right? So this is the way definition for your term as well as preterm neonates. So what about the low birth weight, very low birth weight, extremely low birth? Simple. Any baby who born irrespective of the gestational age, please see to this. Irrespective of any gestation age, if baby's weight is less than 2.5 kg or 2,500 gram, then it is known as low birth weight. Less than 2.5 kg. Very low birth weight comprises of any baby, irrespective of any gestation age. If the baby's weight is less than 1.5 kg, it is known as very low birth weight. What about extremely low birth weight? Any baby was born at any gestation age, if the weight of the baby is less than 1 kg, then it's known as extremely low birth. So these are the few terminology which you must know in and out before sitting for your exam, because this is most basic question an examiner you can expect from an examiner, and you should not make any silly mistake in the definition of the things which I have told. So as I said, there are two important other ratio which the examiner as well as an important 2 mark question. What is NMR? What is PNMR? What is NMR? It is neonatal mortality rate. That means the number of neonate died during first for 28 days of life per 1,000 live birth. So neonatal mortality rate is number of neonate died within first 28 days of life per 1,000 live birth. This is known as neonatal mortality rate. And recent changes, but the recent NMR of our country, you should remember it. In 2014, NFHS, that is National Family Health Survey 4, had told us it is about 29.5. As a whole country, our country at 29.5 NMR, one is neonatal mortality rate. Now the recent, which was done in 2019-21, 2019-21, that is NFHS 5 survey, it is reduced to 18. So our present country, our present NMR ratio rate is 18. So you should remember this. Answer this is why okay question. And what about perinatal mortality ratio? Perinatal mortality ratio is nothing but the number of neonate or number of stillbirth plus neonates died within first 7 days of life. And stillbirth considered any baby was born after 22 weeks and having weight of at least 2,000 grams. 1,000, sorry, 2,000, it's about 1,000 grams. Number of stillbirth includes those baby who's about 22 weeks of gestation and weighs more than 1000 grams, plus neonate who died within first 7 days of life per 1000 live birth. They are known as perinatal mortality ratio, right? Ratio. So neonatal mortality rate is number of neonates died within first 28 days of life per 1000 live birth, whereas perinatal mortality ratio is number of stillbirth plus neonate died within 7 days, first 7 days per 1000 live birth is known as perinatal mortality ratio. So these are the two terminology. Another important terminology that could be asked as your standalone question in as a 1 mark or 2 mark as well as your Viva. Okay. Now, so the most important topic or start topic of today's discussion will be our neonatal registration program, which has been changed recently in 2020. This is very important topic because for both theory, it could be a standalone 10-mark question, and in practical, you have a station, separate station, where the examiner will ask you to perform the basic steps that has to be done during the neonatal registration, and also ask you to tell the equipment that have been used during the registration, how to use it, importantly, how to use self-inflating bag and mask ventilation in a newborn. So if you don't know this topic very well, please see to these videos twice or thrice, revise it because this will be your sure shot question in your 5 mark, 10 mark as well as your practical station. So don't go to the exam without reading this. So I am going to take at least 20 minutes for explaining this topic because this is the sure shot question they will ask no matter what, how much you read any other topic. Without reading this topic, you will fumble in your Viva. So let's go start with this. And most importantly, as you are going to become a doctor after you're completing your exam, you should know this NRP because this is a life-saving thing. And also it will give some kind of satisfaction when you do this and you save your life. That's the reason, another reason why you should know this protocol as well as a whole. Now, so what does this topic normally see to this diagram? So when your fetus is in utero, your lung is completely filled with your water. That is, it's filled with your fluid. So the lung has no role in respiration. So where the fetus get its oxygen and nutrition from, and you all know it is your placenta. So normally your umbilical vein carries oxygenated blood from the placenta to the fetus via three important channels, so that this oxygen will help your major organs like your heart, brain to survive and grow and develop. Rest organs will also develop, but they doesn't require that much oxygen which your heart and brain requires. As a result, your umbilical vein carries oxygenated blood via from your placenta to the major organ through three things. One is your ductus venosus. Now, this ductus from the ductus venosus, the blood goes to your inferior vena cava. This red line, what the red color denotes the oxygenated blood, and then since and then from your foramen oval, that is pattern foramen oval will be open. From that, the blood will reach from right to left shin. Now, what is important of right to left shin? Normally, as I said, your lungs doesn't participate in your oxygenation or in the respiration. So there is no use of your body to send your heart to send this blood back to the lungs, since there is no oxygenation will happen. So as an instinct, the fetus doesn't want to waste the oxygenated blood by sending it to your lungs. Instead of, it has made a shortcut. So as soon as the blood comes to the right atrium, via the foramen oval, it reaches your left atrium. From left atrium, it reaches your left ventricle, and then from your arc of aorta, this blood will reach your brain. So first one is your brain gets the oxygenated blood. About 80% of your FaO2 will be reaching your SpO2, sorry, it is SaO2, saturation I'm talking, will reaches your brain. And in the arc of aorta, it's a ascending aorta, there is some coronary circulation also. So in that way, it also reaches to heart. Heart and brain will receive the maximum amount of oxygen. And then it goes through your um, then it goes to the behind. But what happened? As I said, there are few other blood of from right atrium. Maximum oxygenated blood will shunt it to left, then to left ventricle to the aorta. From aorta, it goes to the heart and the brain. Whereas remaining amount of blood from right atrium reaches the right ventricle. From right ventricle, it enters your pulmonary trunk, and pulmonary artery. Since your lungs is filled with fluid and having an increased pulmonary vascular resistance, now the blood cannot go to the lungs. Instead of your ductus arteriosus will shunt this blood back to from your pulmonary artery into the descending aorta, and descending aorta already carrying the blood from the left ventricle, somewhat oxygenated, and the deoxygenated blood from pulmonary uh, artery will mix with this at the level of the ductus arteriosus, and it will carry all other deoxygenated blood to the rest part of the body through the descending aorta, and from there the umbilical artery will carry the blood again to the placenta for the oxygenation. In this way, the fetal circulation works. But once the baby is about to born, now this has to go for a neonatal transition. The reason is your lung is going to start in the participation in the in your what you say, the lungs will now take part of your placenta and play an important role in the respiration. Once the baby, so what is the step that will happen in your neonatal transition? So one, we always see, once the baby is born, once the baby is born, the first cry will cause into the alveoli. This pushes alveoli into the lymphatic system, and your alveoli will be filled with air. Now, this is the first step. Once the alveoli fill with air, the PaO2, that is partial oxygen in the alveoli, will increases. What does this does? This will causes your pulmonary arterioles to dilate, pulmonary capillaries bar arterioles to dilate. This is the second step, right? Now, once your pulmonary arterioles dilate, now the more blood flows from the so cry. Once the child starts crying, alveoli will be filled with air by replacing the fluid. Second thing, once the PaO2, alveolar oxygen tension increases, it will cause the dilatation of your pulmonary capillaries. So more blood will now start flowing from the pulmonary artery to the pulmonary trunk to the pulmonary artery into the lungs. All this blood get oxygenated. Now this blood returns back to the left atrium via a pulmonary vein and then left ventricle. At the same time, there will be a clamping of your umbilical cord. Once the umbilical cord is cut, the low resistant placenta now become high resistant systemic vascular resistance in fetus is always low, whereas as your placenta has been cut off by clamping your umbilical cord, there will be a raise in your systemic vascular resistance. As a result, the shunting that was happening, the right to left shunt through a foramen oval will get functionally closed. So now the complete oxygenated blood from lungs will go via a left atrium, left ventricle, and then to the aorta. It will be carried to all the important organs. This is the neonatal transition. This has to occur. If any of the steps, one is if your alveoli is not going to filled with your air and the fluid retained in the alveoli, first part, if the pulmonary vascular resistance doesn't decreases, remain increase. Third, when your SVR doesn't increase. Any three of the thing, if doesn't happen in the proper sequence, then the child will have a delayed transition, and he or she will suffer a pathology, no, as we will discuss, that is birth asphyxia. So simple. As I say, first cry. So simple as the child cry first. The baby has to cry. Just give a breath. So the alveoli in this first part, in this diagram you see, the fetal lung fluid will be replaced by your air. As the air enters, it will be replaced by the air. As a result, the PaO2 increases. So PaO2 is alveolar oxygen tension increases. As a result, the above diagram will happen. Constricted blood vessel before birth. After your alveolar oxygen tension increases, it starts open up. So more blood flows from your right ventricle into the pulmonary artery, into your alveolar capillaries. So oxygenation occurs, and then, as I said, once you clamp the cord, clamping the cord, the UVC clamping the cord will causes SVR to rise. As a result, your right to left shunt that happening to which was happening through PFO will stop, will be get closed. As a result, a complete serial circulation will happen to occur. So this is the neonatal transition, circulation to be happening. As I said, any one of the following three steps, if doesn't happen in the proper sequence, then the child will show a condition known as abnormal transition in the form of irregular breathing, absent breathing, or rapid breathing. Because of this, your alveoli is not going to be getting the enough oxygen, so the child will have delayed transition. If the heart rate is slow or rapid heart rate, then the amount of blood that has to reach your pulmonary circulation is get impaired. Even there is proper ventilation, if there is no adequate amount of blood flows to your pulmonary vessels, there is no scope of any oxygenation, and the child will not get the benefit of the ventilation. This is the second thing. Third one is decreased muscle tone, because when the blood is not flowing to the pulmonary circulation, or there is a persistent increase in PVR, that is the baby is not breathing well, and when there is a problem in your ventilation and perfusion, so the child will not get enough oxygenated blood to the muscles. When the muscle doesn't get the enough oxygen, the muscle tone remain decreased, so you will have a flappy baby. Pale skin or blue skin. Blue skin is because of hypoxemia. Pale skin because enough blood is not reaching the skin. So there will be a paleness. Low oxygen saturation, same thing. There is no enough oxygenation of the blood is occurring, either because of defective ventilation or because of defective poor circulation to the lungs. As a result, there will be no oxygenation, and the saturation will be always low, and low blood pressure. As I say, when the SVR is decreased, when SVR is not increased because of hypovolemia, or there's not enough blood flow, the low SVR, so there will be a low blood pressure. So these are the following characteristics we will be seeing in any abnormal transition when the normal neonatal transition doesn't occur. So, so what does the importance of the topic which I discussed right now was that once a baby is born to the world, to in this world, the child has to adapt from fetal circulation to the neonatal circulation, so that he can independently breathe with his lungs, oxygenate the blood, and provide the oxygenated blood for every organ of the body, and he can survive. If that doesn't happen in the sequence I told, then the child will have a delayed transition, abnormal transition, where the pediatrician and ops gynae has to come in the rescue, or else the child will have a severe damage to all the organs, particularly your brain, going to hypoxic ischemic encephalopathy, which in future for that baby will have a severe neurodevelopment uh, impairment, and the child will may develop, most of the time the child develops cerebral palsy. In order to avoid that major consequences, you have to do few steps before uh, uh, before any birth. That is known as anticipation and preparation of birth. Preparedness and anticipation of birth should be done for every birth or for every childbirth, irrespective of the uh, prognosis, whether it was a good baby. If it is a normal delivery without any risk factor, also you must be prepared for that birth, because as you know, 85% had a normal transition without any problem, whereas 10% of baby needs some resuscitation, like in the form of initial steps, and then another 5% required positive pressure ventilation, another 1% required chest compression, another 0.1% required uh, intubation and adrenaline usage. So because of that, you should be prepared for every birth, irrespective whether the delivery will be a normal or there will be no complication. Even there is no complication, you should anticipate that some kind of complication may occur during the time of birth. So what are the four questions to be asked? This is the protocol you should know. Where the first one is, what is the gestational age of the pregnancy? Second, the four questions that has to be asked by a pediatrician or the person who is coming to take care of that baby, the newborn baby. The four questions that has to be asked to the ops gynae people is: 1 year, what is the expected gestational age? Second, any additional risk factors are present in the mother. Third is, what is the amniotic fluid status, whether it's adequate or oligo or poly, and color is so you should know the quantity and what is the color. So in the way of color, you will say it's meconium stain. This is very important. And then your if there is any meconium stain liquid, okay. So meconium stain liquid, blood stain, or is very it's a clear. And last fourth one is, in 2005 when AAP given their guidelines, 2015 sorry, in 2015 when AAP, American Academy of Pediatrics, which when given the guideline, the fourth question was how many babies. Now in 2020 it has completely changed. Instead of asking about the amount, the number of baby, they ask about the umbilical cord management. We will come to this question in short. These are the four questions you must be asking. Then you go for equipment check. What are the equipment you will be using for the warming the baby, for for the airway, for the breathing, for circulation, for so for resuscitation. So what are the instrument you should use? Is that you have to do a pre-resuscitation equipment check and team briefing. If it is any high risk pregnancy or it's a valuable pregnancy, then at least 2 or 3 members should be present for the neonatal resuscitation. And before the delivery, before the birth of the child, you must be counseling the parent about the prognosis of the delivery, whether the delivery uh, will happen in a smooth way, or you are suspecting or you are expecting some kind of difficulty in the labor, so the child may require resuscitation, child may require some kind of respiratory support, or he may require to be admitted in NICU. This are the antenatal counseling and parent counseling should be done for every birth in a hospital setting. So these are the risk factors: antepartum risk factors and intrapartum risk factor. So simple antepartum risk for any preterm and postterm delivery. If any mother's risk factors like a preeclampsia, maternal hypertension, diabetes mellitus, and liquidity, poly and oligohydramnios, IUGR, and there is no prenatal care. This is most important in our city. There are many unplanned pregnancy where the mother doesn't know that she is pregnant, and she comes at the 8th month or 9th month of gestation, in so casually without having any idea that she is pregnant. So the no prenatal care itself an antepartum risk factor, and makes that pregnancy high risk. And in intrapartum risk factors, any emergency C-section, any assisted vaginal delivery like a forceps, breech deliveries, and if the mother is given general anesthesia, magnesium therapy, or any abruptio placenta, vasa previa, intrapartum bleeding, chorioamnitis, meconium state amniotic fluid, or prolapse umbilical cord, that is cord prolapse. If any of these following factors are present in that delivery, then that delivery will become an high-risk pregnancy, high-risk delivery. And for any high-risk delivery, at least three members should be present for the resuscitation. So these are the things which should be equipment check. One is for warm, another for clearing airway, for auscultation, for ventilation, for oxygenation, and for intubation, and for the medication. So in this way, you have to structure the equipment for the resuscitation. As I say, teamwork is must. In neonatal resuscitation, it's never a single man. It's an army. So for NRP or for neonatal resuscitation, the army must be present rather than a single work. Single man cannot perform NR unless it's a normal delivery without any complication. One person is enough. For any high risk for delivery, it's always better to have a team. So pre-registration team briefing, we assess the risk factor, we identify a team leader, and we have to discuss about the potential complication. For that, we have to make a team response. You have to delegate tasks for every member who is present in the team, and you have to add a person who can document event as they occur. That is, they are known as scribers. Unless it determine what supplies and equipment will be needed, so that is the equipment check. And when any problem appears or occurs where among your team member cannot do that particular task, then you have to also identify how to call for an additional help. So this is the overall your NRP guideline, which we will discuss in detail. Okay. So scenario one, simple. If a child had cried after birth before any delivery, and if a child cried after birth, this is normal scenario that appears. It occurs in sorry, occurs in 85% of the delivery, which I said earlier. 85% of the delivery, the child cries. So they have a normal transition. So what you will do for this baby? As per the recent guideline, in any hospital, any child who was born or in a normal vaginal delivery, cried immediately after birth, you go for a strategy known as routine care. So what is the routine care? Once a child is born, the child has to be put, the baby or child has to be put over the mother's abdomen. There is no need to separate the baby from the mother and take to radiant warmer for any vigorous child. This is known as vigorous baby. Any vigorous baby who born and cried immediately after a birth by a normal vaginal delivery, please put the baby by covering with a pre-warmed linen and put the baby over the mother's abdomen. Dry the baby with pre-warmed towel, that is pre-warmed towel. Then suction if needed and position the baby over the abdomen. Position the baby. Cover the baby with a pre-warm linen. Initiate breastfeeding as soon as possible, that is within 1 hour of delivery, and monitor vitals. For this baby, after starting, so what is the importance of this topic is if your baby cried after the birth, there is no need to separate the baby from the mother. Keep the baby over the mother's abdomen, dry the baby, position the baby by keeping the head towards the one side so that the child will not suffocate. And third thing is you have to suction if needed. Once you dried, cover the baby with a dry towel and initiate breastfeeding. you have established skin to skin contact and minor monitor vital. For this baby, the cord should be clamped after 60 seconds of life. After 60 seconds only cord clamp must be done. Right? Right. Okay, this is routine care. If the child cried, this is the important thing. And what about the vitamin K injection? What about the hepatitis B injection? What about the weight? After 1 hour, after initiating breastfeeding, after giving a skin to skin contact for minimum 1 hour and breastfeeding has been initiated, then you can separate the baby and take for the routine checkup, like your vitamin K, immunization, as well as your weighing the child. Scenario 2. If the baby cried, baby is a term baby, but didn't cry and limp after the birth. So this kind of baby, what you have to do? Once you see a child is a term but didn't cry and the child is flappy, don't waste any time. Clamp the cord, bring the child to the radiant warmer. The radiant warmer should have been started at least 30 minutes before the birth, even before the delivery, before anticipated delivery, 30 minutes before the radiant warmer should be on. It should be preheated for minimum 30 minutes and then receive the baby in the warmer. And you have to follow this step called as warm DSP. That is initial step. Warm DSPS, right? Now, what is about this warm DSP? Simple as that. So this is known as initial steps. So what are the initial steps you will be doing for any child who didn't cry and a flappy but a term child? Warm. As I said, keep the child under radiant warmer. Then dry the baby. Dry the baby by your pre-warm towel over all the body, your head as well as your trunk region. While drying itself, this is kind of a stimulation. Most of the child during drying itself, the child start crying. Then there is no need for separately. There is no need for to stimulate. Even after drying, if the child is not crying, then you can stimulate the child by flickering the. You can flicker the toes. One, you can flicker the uh, you can flicker the mm, sole under feet, palm of the child, and most of the child will cry. And then even after that, the child is not crying. Then you position the airway. What is this positioning the airway? Is the sniffing dog. So you are seeing the correct sniffing position. You have to slightly extend the head so that your airways get unified. What that means is your mouth, then your larynx, and your trachea. This will become a straight line. Get it? When it becomes a straight line, so the air will now enter directly via trachea into the lungs, and the child will get ventilation, and the child start crying. So for the position the air, this is known as sniffing position, for which you can use a shoulder roll. This is the shoulder roll given here in the picture. And then even after the child is not done, you do a suction if needed. For suction, you use a 10 to 12 French one. Okay, you use 10 to 12 French suction catheter with a pressure of 80 to 100 mmHg, which is wall suction catheter. So wall suction, vacuum suction of 80 to 100 mmHg of 10 to 12 French suction catheter can be used. In this diagram, we are using a bulb suction. So after doing this warm DSPS, most of the time child cries. If a child cries after doing these steps and add a good color, tone improved, color improved, heart rate is more than 100, then you can shift to the mother's side, monitor the child, vitals, and do a routine. Now, other scenario is meconium stained liquor. In initial days, if the child had aspirated the meconium and the child had a meconium stained liquor, initially what they do is before the child shoulder is delivered, they do this bulb suction, they intubate the child, they do a tracheal suction. But recent guidelines, they have clearly delineated the fact that without doing that also, the child may have uh, he even after doing that also, the prognosis of the child is not going to change. So instead of that, we can do a normal routine steps which we are doing, like your warm DSPS and positive pressure ventilation. So like that itself is more than enough rather than the tracheal section. So the so so what is the tracheal suctioning is not recommended right now, which was initially was in initial guidelines were present. Now tracheal suction is not recommended for any vigorous baby with meconium state liquid. Routine care, initial steps which I discussed before will follow the same. But for a non-vigorous baby who doesn't cry, perform the initial steps, warm DSPS, then assess the heart rate and respiratory pattern. If it was not normal, then go for the positive pressure ventilation. If it is normal, continue with the post uh, care. But this PPV, even after the child is not improved, and you are seeing important point. If you are noting, if you are noticing a large plug in trachea of the child, that is meconium plug of the child baby, then in this scenario you intubate and remove the plug. As a result, the child will then you uh, you have to extubate the child. Once you remove the plug, extubate it and do the positive ventilation. Then the child may improve. So in this is the only scenario where you have to intubate and suction is that when the large plug is impacting the trachea of the child, which prevents the proper ventilation of the lung. After initial steps, you are going to see two things. Once a meconium stain liquid is for another, it's a special scenario. After the initial step of warm DSPS, right? You're going to see whether the spontaneous breath heart rate more than 100 is present on. If the baby is crying, heart rate is more than 100, the child is respiratory pattern is good, and the child tone improve, movement increase, then you have to assess whether there's a labor breathing or not. If there is no labor breathing, routine care, shift to the mother's side, right? If there is a labor breathing, then you see connect pulse oximeter, check for the saturation, right? Check for the saturation. And if the saturation falls below the level which is required for that particular minute, you know that 1 minute, 2 minutes, 3 minutes, 4 minutes, 5 minutes, and 10 minutes. For a normal newborn, the saturation of more than 90% will appear only after 10 minutes of life, not before that. At 5 minutes of life, a normal newborn saturation is just 80 to 85%. This is very important because in most of the time, what we do in 3 minutes of life itself, we see that the saturation is 75%. Then I have to improve it to 90%. So I will give a supplemental oxygen. There is no need of giving supplemental oxygen at 3 minutes of life. The reason is for 3 minutes of life, the saturation will be 70 to 75% only because there is a transition. As I said, as a fetal to neonatal transition takes time of at least 10 minutes. First 10 minutes, the child will transit from a fetal life to the neonatal life. So saturation will slowly improve from the 60%, which was the fetal life saturation, to the 90% at the 10th minute of life. So before that, the saturation will be low, and for that, a timeline has been given in your neonatal resuscitation protocol as a chart. At what minute, how many saturation is normal? For 3 minutes, 75% is normal. So in that scenario, you never given supplemental oxygen because that will determinant to the child only. So see according to the what time for time duration the child saturation is that. If the saturation falls within that normal category, then there is no need of any oxygen. If the oxygen is below the accepted range, Then you give a supplemental oxygen. For many preterm babies, they have spontaneous breath heart rate more than 100, but they have a label between go for the CPAP. If the baby is gasping, this is the one name. If the baby, after initial step also the baby is gasping, heart rate is less than 100, go for a positive pressure ventilation with the help of self-inflating bag. Now, this is the thing which I said. If apnea or gasping, heart rate is less than 100 beats, yes, then go for positive pressure ventilation. That is where self-inflating bag. See, instrumentation we will be discussing in separate video, because if I start to explain all this instrumentation also here, it will take more time. So I don't want to waste much time, because we have to concentrate on other topics. So just note these points. In the instrumentation class, which we will be discussing, we will discuss about the self-inflating bag, with which you will give this thing. Then you have to connect to pulse oximeter, consider cardiac monitor. Now, after giving the self-inflating bat, use this thing, which I will discuss. This is the self-inflating bat. So you see, this is a reservoir. This is your back, self-inflating back. For neonates, we use around 250 to 500 ml of self-inflating bag. Okay, this is your face mask. See, the face mask must be appropriate for the baby. For baby, it is different for your preterm, extreme preterm, and your term baby. The size must be seen. It must only cover your mouth and the nose. It should never cover your eyes. So face mask. Then your self-inflating bag of the volume of 250 to 500 ml. This is oxygen tube. And there must be a, when you go for this pump, that is your patient in, a fish mouth wall will be seen where your face mask. This is a face mask you will apply. Use a fish, uh, sorry, this not fish, it's a fish mouth wall. Sorry, fish mouth wall, that is in outlet wall. Then we have a pop-up wall. This pop-up wall is mainly because of for your pressure. So normally the pressure should not go beyond 40. If going beyond 40, then the child will have a barotrauma. In order to prevent it, this is a pop-up wall which act as a safety wall. So these are the thing which you will see in a mask. So this is the easy clamp. Once the child, you have to give a positive pressure ventilation, position the child, and the first position you have to do an easy clamp. From the chin towards the nose, you have to apply, and then you have to hold in the way of easy clamp, which is shown. This is a C, and the three finger will be having a E. This is E, and this is C. And for this is the neonate. This is another. This is what this device is used is a TPC system, which we will discuss in other class. TPC system in one. For giving positive pressure ventilation, you can use three things. One is your self-inflating bag, right? Another one is your flow inflating bag. The last one is your TPC. This is a recent addition. In most of your hospital, if you go to a labor room and you go for the newborn stabilization unit, that is newborn corner, you will see the TPC resuscitator one, because this is recent advance which helps in providing a adequate amount of positive pressure ventilation to the child, which benefits the respiration on the child. So do a PPV for 30 seconds. So this should be carried for 30 seconds. Initial steps for 30 seconds. After that, we do a positive pressure ventilation for 30 seconds. For first, in this 30 seconds, first 15 seconds, you have to see whether the positive pressure ventilation is working or not. In what way you will see whether the positive pressure ventilation is working or not? It's by your chest rise. If the chest rise is adequate, what is mean by adequacy? That at least the chest rise move upward. That is the adequate chest rise. If it is adequate, then continue for another 15 seconds. That is total 30 seconds. Even after that, but if the chest rise is not adequate, you are giving for 15 second positive pressure ventilation. Even after 15 seconds, there is no chest rise adequate. Then you have to see there is any problem in the chain, whether that's a leak from the mask, or there's an airway block, or the pressure is not adequate. So you have to do a step called as ventilation corrective step, right? This is the MR SOPA ventilation corrective step, that is mask adjustment, reposition the head and neck, suction the mouth and nose, open the mouth, then pressure increase, finally alternate airway. First you do mask adjustment and reposition the head and neck, do it again. You give 5 breaths and assess the chest movement. If no chest movement, then you go for SO, that is to suction the mouth and open the mouth. Even after doing this, the child chest movement is not adequate, then go for increase the pressure. Even after that, the chest rising is not adequate, then go for the alternate airway. So this in this way you go for MR SOPA ventilation corrective step. And positive pressure ventilation, what are the initial setting which you must know is for any less than, this is a recent addition. Initially we were telling that we can give about 100% at initial days they were giving the IFIOT of 100% at starting itself. But now they are saying giving 100% is to the baby will cause determinantal consequences like retinopathy of prematurity, brain damage, reactive oxygen species related injuries. Due to this, they came with the concept that with room air itself, you can start resuscitation. For any baby of more than 35 weeks gestation, gives the initial setting of 21%, and if it is less than 35 weeks gestation, give the initial setting with 21 to 30%. Gas flow at 10 liter per minute with your blender. Blender is nothing but which mixes your both air and oxygen, that is known as blender. Rate should be around 40 to 60 breaths per minute. Positive inflatory pressure should be 20 to 25 centimeter of water, and your positive end expiratory pressure should be 5 centimeter of water. This is the initial setting for the positive pressure ventilation. So this is a TP resuscitator which we use because this gives both PIP, PEEP. You can adjust them, but the disadvantage is they require a gas source. Without oxygen support, they cannot give, whereas your self-inflating bag, which I was discussing, doesn't require any gas. So with the room air itself, you can perform. So in a resource limited setting, we use self-inflating bag, whereas where there is resource present, like in a medical college hospital, we with the TP sensitization. This is the recent update, and guidelines recommends this use should be preferred in the, if it is present, always go with the TPs rather than the self-inflating bag. So indication of pulse oximeter when registration is anticipated to confirm your perception of persistent central cyanosis, when supplemental oxygen is administered, and when PPV required. These are the 4 indications where you have to give pulse oximeter. Now, after doing positive pressure ventilation for 30 seconds, so perfect. You have given effective positive pressure ventilation. There was an adequate chest rise, and despite that, there is no spontaneous breathing. And suddenly, you are noticing that the heart rate falls below 60. What you have to do? Whenever a child who has been given an effective ventilation with the positive pressure ventilation via self-inflating or your TP resuscitator, and there was an adequate chest rise, and even then the heart rate was not improving, and suddenly the heart rate goes below 60, that means the hypoxia is continuing. This hypoxemia now reaches to the heart muscle. The heart muscle has now not received any oxygen, furthermore oxygen, it is deprived of oxygen. Now muscles of so the myocardium start fatigue and the heart rate start to decrease. So less than 60 minutes, the heart rate has start to decrease because of hypoxemia still continues. So in this case, you have to start chest compression. Before chest compression, what are the priorities prerequisites you have to do? You have to intubate the child if you haven't done it. Intubate the child. Second, connect to ECG monitor and turn your FiO2 to 100%. Before, whatever be the FiO2 you have kept, that doesn't matter. But when you start chest compression, you have to increase it to the maximum 100% and start chest compression. So you have to intubate. So this is the view which you see. You have to visualize with the help of the laryngoscope blade, particular preterm and term. We have different size of blade. Zero for preterm, one for term baby, and then you have to use your laryngoscope and visualize the glottis directly, and then push the ET tube according to the age and the weight. It is the chart we use. If it is below 1 kg, 2.5 mm, 1 to 2 kg, 3 mm, greater than 2 kg, 3.5 mm ET tube should be inserted through the right side of the angle of mouth. Then it has to fix. Position must be checked and then fix the tube. After fixing the tube, one of the member who is going to give the chest compression should be over the head end, as the picture tells here. The one of the members should the person who is going to give chest compression should be over the head end of the child, and you should use the two-thumb technique. So what technique you should? Two-thumb technique, no two-finger technique. Two-thumb technique. That is, the two-thumb should encircle the entire chest of the child, and the compression should be two-thirds of the AP diameter of the chest. It should be at the lower end of the sternum, just above your GP sternum. Not never press the GP sternum, because GP sternum, if you press over the GP sternum, it can go for the liver injury. So lower end of the sternum, just above GP sternum. And rate is 3:1 for 2 second cycle. 1.5 seconds should be for your chest compression, and off for the ventilation, which is shown in this following picture. Two-thumb technique is the important thing. We never use two-finger technique. So this is the thing. So the compression depth is approximately, so 1/3 of the anther. It's not 2/3. Sorry, it is 1/3 of the anteroposterior diameter. Landmark of the chest compression is above, just above the GP sternum, the lower 1/3 of the ear, and this is a two-thumb technique must be used. Last scenario, even after giving an adequate amount of chest compression with effective ventilation, 30 seconds, chest compression with effective ventilation for 60 seconds, you have intubated the child. Despite this, the child heart rate is not improving and it's still less than 60. What you will do? Now you have to give some drug, because the art has not the art has gone to a such extent that even giving your manual compression also, the art is not working. The myocardium is failing. So in this scenario, we give some drug to regenerate, to provide energy to the cardiac muscle. So in that way, we give the drug called as norepinephrine. So norepinephrine, the dose is 0.2 ml per kg or 0.02 mg per kg. That should be given to umbilical vein. The umbilical vein with 3 ml NS flush, which can be repeated for every 3 to 5 minutes till the heart rate improves. Once heart rate improves more than 60, then stop giving norepinephrine, stop chest compression, then go with just positive pressure ventilation till the child has spontaneous respiration. Even after that, the heart rate is not improving, is less than 60 seconds. Continuous chest compression, give positive pressure ventilation via ET tube, and give another dose of norepinephrine. Sorry, it's not epinephrine, it's epinephrine. I'm very sorry, it's epinephrine. After giving of 2 or 3 doses of epinephrine, giving a adequate amount of chest compression, adequate amount of ventilation, and 2 3 dose of epinephrine, the child condition is not improving. Then the one important thing, see, is you have to consider hypovolemia and pneumothorax. So treat according if hypovolemia, if you are suspecting if there was a case of APH, the old obscenital disorder, there was an placenta previa, or there was a abruption placenta, then that in that instance it will tell that this is because of APS, the blood has been lost, the child is in hypovolemic shock. So whatever you will do without replacing for the hypovolemia, the child will not respond. So go with the hypovolemia correction. So what is the correction you will be giving? It is your NS bolus. 10 to 20 ml, 10 to 20 ml NS over 20 to 30 minutes. Right? Okay. So this is 10 to 20 ml NS bolus you are giving, followed by, or you can give O negative whole blood, can also be given. For pneumothorax, you have to go for needle thoracentesis, followed by ICD placement. So what are the recent advances? So this is the thing which you will be told. So we took a lot of time in explaining the NRP, the reason behind to explain the NRP for you, because it is one thing is very important for the university biowork as well as the practical. And as a doctor, you should know what is NRP, how to do it. There are many videos that is available in the YouTube. See to it, read once, and again see to this video. It will be helping you a lot. Now, what are the recent advances which is seen is thing is delayed cord clamping. What is delayed cord clamping? Delayed cord clamping is nothing but you have to clamp the cord after 30 to 60 seconds of life. The reason is it will give more blood to the baby. As a result, it will improve the hematocrit of the baby. It's about a term baby. If it's a term baby, then it prevents and give iron store and prevent the physiological anemia that appears normally during the 6th month of life. Right? Now, for preterm baby, giving 60 seconds of extra blood will help in the smooth transition and also uh, will prevent fluctuation in the blood flow to the brain. So it prevent major important preterm comorbidities, so intraventricular hemorrhage. In term baby, it improve hematocrit, iron store, so physiological anemia nahi hoga. But preterm, that 60 seconds of extra blood will help in the smooth transition and also it prevent the fluctuation in the blood flow to the brain. As a result, it prevent the intraventricular hemorrhage. And another thing is ET tube placement. Once we have placed the ET tube in the baby, you should know at what depth the ET tube should be fixed. It is given by the measurement called the nasotracheal length plus 1 centimeter. This is a recent change. Okay. Laryngeal matrix airway, we will discuss in another class. So this what are the levels of newborn care? So according to what are the level, there are level 1, level 2, level 3, level 4. Level 1 is a normal term newborn who with the age of 35 to 36 weeks. And so these are mostly level which are along with the mother's side. So most of the child with the mother will be placed in the level 1, and any baby who gets sick in this level will be stabilized and they would be referred to the second center, that is level 2. In level 2, neonates of 32 weeks or more of gestation or 1500 gram or more at birth will be taken care of. Moderate sickness babies will be taken care of. In this unit, we can give CPAP and brief ventilation. And level 3 is less than 32 weeks and less than 1.5 kg, and those baby will suffer from birth asphyxia, a critical illness, and here we give the invasive ventilation like your ventilator setting. In level 4, it's a subspecialty department with pediatric cardiology, pediatric surgical department with ECMO machine. Full advanced setup will be present in the level 4. In National Health Mission, what are the according to National Health Mission, what are the level of newborn care? One is your newborn care. Sorry. Yeah. So this is important for you. So according to NHF, we have three care. You should know newborn care corner, newborn stabilization unit, and SNC. Newborn care corner is present in every center, in even a sub center or sub health center or your PSC must have a newborn care corner at every labor room where the baby will be stabilized, will rest, basic NRP will be done, and then if the child is not improving, the child should have been sent to the higher facility. And second, newborn stabilization unit is provide signal for above 1. This NBSU is given more than 1800 gram babies is present in your CSC. And first referral units. SNCU less than 1800 gram babies, sick babies for NNJ, and we can give CPAP here. So, care of normal newborn after birth. What are the five cleans you should know is one is clean cord, clean towel, clean and right? Then clean surface, clean cord, clean tie, and most importantly, not apply anything over the cord. That is the key. This sort of cleanliness should be done for every newborn delivery. And how you prevent hypothermia? As I said, dry warmer, radiant warmer. You have to dry the baby as soon as the child is born. If it is a vigorous baby, go with skin to skin contact, proper clothing, use socks, use cap, swaddling the baby. And in case of any preterm baby, this is important. Preterm baby, how you will prevent hypothermia? One, the temperature of the room, temperature of your labor room should be 26 to 28 degrees Celsius. This baby must be received in a radiant warmer. Never dry the baby. For preterm baby, less than 1.5 kg and less than 32 weeks baby, never dry. Instead of put the child over the plastic bag that is specially created for the preterm babies, use a bed warm mattress warmer and use neonatal incubator for transporting the child. Neonatal transportation is very important here because you have to use an incubator before transferring the child from the LR to the NIC. So these are the important thermal care you should take for a preterm baby because one of your university question in for Tamil Nadu MGR University, I am telling uh, in this recent March 2023, last your senior batch had a 10-mark question on the preterm babies. Preterm babies. So in the preterm complication, one of the major complication is your temperature management. So among that, these are the things which you should see for any preterm delivery. What are the care you should take to prevent the heat loss? Then cleaning of the baby, dry, never remove the vermis caseosa, and placement of the identifier. So care of number initial few hours after birth beyond fear. Initial few hours, as I said, after 1 hour of initial stabilization with the mother, skin to skin contact, initiation of breastfeeding, weigh the baby in a electronic scale, examine the baby for any anomalies. What are the anomalies you will be seeing? Hmm. What are the anomalies you will be seeing for any baby? You see anal patency, You will be seeing cornal atresia. You will be seeing esophageal atresia uh, by passing Ryle's tube. Then even anal patency, any meningomyelocele, or any spina bifida. Most importantly, any gross anomalies. This has to be checked within the and then initiation of breastfeeding as soon as possible. This will be answered or else at least within 1 hour of life. Vitamin K for less than 1 kg baby, go with vitamin K of zero point 0.5 mg. More than 1 kg baby, go with a dose of 1 mg. And the vitamin K we prescribe is vitamin K1. And always rooming in co-bed with the mother because it will improve skin to skin contact, prevent hypothermia, prevent infection, and also helps in the bonding. After few hours, care of the cord, it takes at least 7 to 10 days to fall off. Never put anything over the cord except for the medication if the child is having some kind of omoplitis or that is umbilical cord infection. And the way the cords fall off by a method called as aseptic necrosis. Exclusive breastfeeding for next 6 months. Position of sleep mostly advise the mother to be in the supine position, never in prone. Prone should be done only by the under the guidance of the health care provider. Bad child rearing practices are like what are the things? This could be one of the two more question. One is applying kajal over the eyes or applying cow dung over the cord, oil installation, getting it, okay? Applying kajal oil, applying cow dung, oil installation. These are the things they will earn. And yeah, giving prelactal diets. What is prelactal diet? Prelactal feed. Even before breastfeeding, whenever anything that is given before the initiation of breastfeeding is known as prelactal feed. In our country, we give mostly honey, donkey milk, which are kind of prelactal milk. These are the prelactal rearing practices. So, what are the discharge criteria for a normal newborn? There must be a normal examination, adequacy of feed, received all immunization that is hepatitis B, OPV zero dose, and most importantly, what you give. Yes, BCG. Mother is confident enough in taking care of the baby. There is no significant illness or jaundice while discharged. Danger sign is explained. Follow up for any child who has been discharged within 48 hours of life. Then they have to be followed up in next 24 to 48 hours to review for jaundice. If the child is discharged after 72 hours of life, if there is no risk factors and child is breastfeeding very well, then reassess the child at 6 weeks of life. If there is any risk factors and the child is discharged after 72 hours with risk factors like low birth weight, SGA, IUGR, hemolytic jaundice. Hemolytic jaundice will stay for a while. If that was the case, then you have to reassess the child again after the 24 hours of discharge. And also, most importantly, advice regarding the mother health. Ask the mother to have an healthy, balanced diet, healthy diet, drink adequate amount of water. It's about the mother. The reason is if the mother having a good healthy diet and she has a good hydrate or well, have a positive mental health, these are very important, or else she can this all helps in her breastfeeding. Because breastfeeding is the only food source for the child. So in order to help the mother to give a good amount of breastfeed to the child, the mother health should be taken care of. So these are the warning signs you have to explain to the mother if there is a difficulty in feeding, convulsion, lethargy, fast breathing, severe chest syndrome, temperature of more than 37.5 or below 35.5, yellow soul. If any one of the following is present, the child must be taken to nearby tertiary care center or hospital with newborn setup immediately without any delay. And to all of you, you should know that in newborns, sepsis, infection always presents with hypothermia, or we say it as temperature instability. There is no terminology of hypothermia or the child is having fever because fever is less specific sign that is noted in newborn. Always sepsis, septic shock, or any illness in the child always present with a cold stress or hypothermia. If in that scenario, you have to rule out sepsis in that child. So transient neonatal phenomena, there are few anxious, the patient get anxious about few conditions that is physiological in neonates and they wake up you at night for medical advice for the same. How to counsel them? So what are the few transient cutaneous neonatal phenomena which is seen? Just picture wise I will not discuss the detail because we are running out of time. Okay. So first thing is malaria. So first picture what you are seeing is a milia. What is milia or malaria? This is nothing but your sweat gland, right? The sweat gland obstruction. The sweat gland get obstructed. As a result, the child will have a pearly white appearances, right? You are noticing it now. It's a normal phenomena that you should. There is nothing to be done. There is no need of application of any cream. The child, what do you say? It resolve on its own. Just reassurance. And what this black structure, black bluish you are seeing, this is your Mongolian spot. I hope you know this. Such a picture, it's a picture-based MCQ kind of thing I will be discussing. So it's nothing but when your dermal melanocytes fails to migrate, when the neuronal crest cells, if it fails to migrate, and it stay in a dermal layer, then it go for the Mongolian spot, which is more common in South Asian, African descent, and it is more commonly seen in the buttocks and back. Most of the time, it is single and multiple and coalish like that. It coalish together like the thing which you are seeing here. Most of the time, it is benign and has no uh, any any connection with any serious illness, but there is something when there's an extensive Mongolian spot. Remember, any extensive Mongolian spot, they have linked it to it some lysosomal storage disorder or glycogen storage disorder, not lysosomal storage disorder, like Niemann Pick, Tay Sachs, like that. Okay. Now, another this picture showing some kind of uh, pinkish rash over the neck. These are nothing but your stroke, stroke, stroke mark. A stroke or stroke mark, which is nothing but benign capillary malformation. And this are nothing but this is erythematous over you have a rashes with erythematous base. We have maculopapular, we can say it as um, maculopapular rashes or sometimes vesicle with erythematous base that develops the 2 to 3 days of life. And they have one important thing is they have eosinophil in the microscope examination. So it is a erythema toxicum neonatum. It is also a benign condition that is no need to treatment. This is where breast enlargement in both male and female. This is mainly because of maternal hormones, right? This is peeling of skin. This is also some kind of this normal wherein though there is no need of doing anything, just reassurance. What is this whitish discharge? This is whitish discharge per vagina. Is this any pathology? Absolutely not. It's also uh, transit phenomena because of maternal hormones that is passed transplacentally the child will have. Now this anxious mothers come that my child, this is one of the mother who came anxious to the OPD and telling that our child is passing this kind of urine along with kind of color, pink color. She's afraid that this kind of immature. When you image it, when you examine that particular thing, you can see some kind of pinkish thing. This is nothing but pink crystals. It is a urate crystals. This is occur because of inadequate breastfeeding. So the child is going for dehydration and she's having a urate crystal formation. And that urate crystals, right? Sorry, that urate crystals is the senior. Okay. So urate is also normal thing. Sorry. So another important thing is what is erythema toxicum neonatal and transient neonatal pustulomelanosis. Erythema toxicum neonatal appears 24 to 42 hours of life, but it is present at birth. Your neonatal pustulomelanosis. The small papules and they become pustules and they have an erythematous halo is your erythema toxicum neonatal. Whereas transient neonatal pustular melanosis will present with anything like pustules, mostly at macule. It may also present as vesical pustules, but there is no erythema. They doesn't occurs on palm and sole, which is your erythema toxicum neonatal, whereas the transient neonatal pustular melanosis occurs over palm and sole. Lesion do not result in hyperpigmentation in erythema toxicum neonatal, but some kind you have a hyperpigmental macula and colorate in your transient neonatal pustular melanosis. In microscopic examination, it is not given here. In erythema toxicum neonatal, it is eosinophil abundant. You will be seen in the base, whereas here it is a neutrophil. Simple. Right? So this is the difference that will be asked in your viva as well as your university. What is the difference or what is erythema toxicum neonatum and what is transient neonatal pustular melanosis? So in Apgar score, this is the table which you should come. There is no other way, but you should know what is Apgar. Is appearance, pulse, grimace, activity, respiration. Total score will give 10. Maximum score is 10 and minimum score is 0. So 0 to 3, 4 to 6, 7 to 9. 0 to the bacha has this 7 to 9 means okay. This child is okay. Has moderate depression, but severe depression. Why this? This is a birth aspiration. For birth aspiration, severe birth aspiration, moderate birth aspiration. So what are the normal finding you'll be seeing? Heart rate in a term baby it's 100 to 160. Preterm it's about 120 to 180 beats per minute. Accurate temperature is 36.5 to 37.4 degrees Celsius. Capillary refill time normally we see in two area. One is sternum. Over the sternum you will count 001, 002, 003, 004, 005. And after that, if it is less than 3 seconds, well and good. If it's more than 3 seconds, then the child is most probably suffering from shock. And respiratory rate is 40 to 60 breaths per minute. Any breath rate more than 60 breaths is known as tachypnea in the newborn. Right? So anthropometry, Weight, a normal Indian average weight is 2.9 kg. Length is use your infantometer, exactly 50 centimeter. Head circumference is 33 to 37 centimeter visible. And ponder index means what? Ponder index is weight in kg, width, length in centimeter cube. Because we are if it is less than 2, we go for IUGR. It is not rule out IUGR, which is symmetric and asymmetric IUGR. We use this ponderal index. So expanded new Ballard score. We have two components. This is important to the university 2 mark question. Also Viva question. If you have a neonatology table, they will ask how you assess the age. This is simple for the assessment of age, week of gestation, by seeing two parameters, neuromuscular maturity and physical maturity. With that, we'll be scoring from -10 to 50. -10 correspond to 20 weeks of gestation and 50 correspond to 44 weeks of gestation. So you have to see this one table once. It will be asked in the question. So what are the physical characteristics of term versus preterm baby? This is also one of the important Viva question, your table question, and also your questions will be asked in the theory. One is your ear cartilage. See, this ear cartilage is the ear lobe is well formed, it recoils well, and the cartilage comes till periphery, right? Whereas for a preterm baby, see, the ear coil is not that much well formed. This is just soft, and the cartilage doesn't reach up to the periphery. So one is this is the differentiate the term preterm, and it's a male baby. You see a pendulous, deeply pigmented scrotum with descended testes. Whereas in a term baby, it is simple scrotum which is not no well formed, no rugae, not a simple scrotum, not so much pigmented, and undescended testes. Right? About the soul, you will see a well demarcated anterior crease in a term baby, whereas there is just faint mark or reddish hue will be seen in a preterm babies, right? And when I'm coming to the breast birth, it's well formed and it will be more than 5 mm in a term baby, where it will be very faint. There will be no breast, there is no areola or no breast. It's not a even less than 5. And when comparing to the R, silky kind of hair will be seen in the preterm babies, where a preterm you have fuzzy hair. And Lanovo hair will be more commonly seen in your preterm babies rather than the term baby. Labia majora minor, normally in a term baby, the labia majora covers. See here, this is the labia majora. This well covered your labia minora in a term baby. But in a preterm baby, see, this is a labia majora and this is your labia minora. So both are prominent. So both prominent of labia majora and labia minora is seen in preterm, whereas in term, the labia majora covers well your labia minora. So in this way, you can differentiate a term versus preterm babies via the physical characteristic. This characteristic is also seen in your expanded new Ballard score. Both neuromuscular maturity as well as physical characteristic will be used for grading the gestational age of the newborn baby, and the expanded new Ballard score can be used up to 96 hours of life. Right? Got it. Right? Okay. So now differentiate. Now we will see something important thing. What is caput succedatum and cephalometoma? Caput succedatum is very common. This is boggy erythematous swelling of the fetal scalp. It disappears without treatment. There's no pathological symptom. This is because simple. Whenever in a normal virtus pregnancy, in a virtus delivery, the head is the engaging part. It is the dependent part. So when the head is the dependent and engaging part, what happened during the delivery takes time for the head to come out. So that since becoming a dependent part, all the water get lodged over the scalp. And now, since the head molds towards the through the maternal pelvis is mold, this fluid get accumulate and it form a boggy swelling called as caput succedatum, which is a normal physiology and it resolves on its own within 24 to 48 hours, maximum 3 to 4 days. Okay, so it is a common, it is location subcutaneous plane, maximum size is seen at the birth, softens progressively from birth, it is diffuse and crosses the future line, and association none. Whereas the cephalometoma is very less common, it appears over parietal bone and it is subperiosteal swelling. So this is your cephalometoma. This is a subperiosteal swelling. And it increases size for 12 to 24. Initial, you will not see any swelling. If any swelling that is maximum at birth and it progressively decreases, it is caput succeedum. If it is minimum at birth and it progressive to attain the maximum size at 12 to 24, and it is limited to a single suture over the parietal bones and firm thing, and that is then it is a cephalometoma, and it takes 3 to 6 weeks to resolve. And it are always associated with the linear skull fracture and hyperbilirubinemia. This is important 2 mark, 5 mark, 5 question, right? So, okay, signon. So, what is signon? So, any delivery that is assisted with vacuum in vaginal delivery, the vacuum exerted over the head of the fetus will create an artificial swelling called chignon, right? This is chignon, right? And it resolves on its own. There is no need of any. And sometimes because of blood, the child may go for hyperbilirubinemia. So any babies, when 8 to 2 examination, you have to see, as I say, cornal atresia, microcephaly, wide open fontanelle. Wide open fontanelle is seen in which other condition? Very good. Down syndrome. Yeah, crying baby is the most common. When your baby is crying and you're seeing the fontanelle, it is wide open. Sorry, not it's a tense fontanelle. I'm very sorry, it's not venture. Down syndrome, then your raised ICT, congenital hypothyroidism. So these are three projects. You have to see for the Down syndrome, raised ICT, congenital hypothyroidism. Exactly. Osteogenesis imperfecta. Anal patency, ambiguous genital is very important. Any hypospadiasis, any clitoromegaly, not any penoscrotal hypospadiasis, clitoromegaly, micropalace, that is micropalace or penis, if any present, that is to be then sex of the baby should not be revealed. In that scenario, sex of the baby, hypospadias, that is penoscrotal type of hypospadiasis, clitoromegaly, micropalace, micropenis, if any of this particular condition is present in that baby, please don't reveal the sex of the baby. Perform a karyotyping and do USG whole abdomen with KUB to know the internal genitalia organ. After doing that only, you reveal the sex. Before that, there is no assignment of sex in that kind of babies. Then I said meningomyelocele, occult spina bifida, single umbilical artery. This is very important. Umbilical artery. This question is important about this mostly common 0.7% of live birth. You will have a single umbilical artery. Most common associated anomaly with single umbilical artery renal, followed by cardiac, followed by GA. And last CTV and DDH. You should be seeing. Neonatal reflex, you should read it. And so what are the reflex? Which is sucking, rooting, palma, asymmetric tonic, symmetric tonic, moro reflex, and parachute reflex, which you should know. So these are something you should have to read. must known topic. I'm not going to discuss because you have to cramp it. No other way. If I explain it also, that's not going to help. So about the motor reflex, one thing I have to expect this motor reflex is, see, motor reflex is something the child, whenever this reflex should be performed when the child is not crying, when the child is somewhat in quiet state, sorry, right? In a quiet, awake, or sleep state, never perform while the child is crying. So, how to perform? Simple. You have to hold the baby with two hand, one hand over the head and one supports the back of the baby, and then you suddenly from above suddenly uh, uh, drop the baby head from the above, and with the same hand you have to again pick up the baby with the support. Please see the video. Without seeing the video or before doing, if you don't know, ask the senior, ask your residents who is in your ward to demonstrate it, because I cannot demonstrate here. Before, without knowing the thing, don't do the same kind of reflex, because this is not somewhat tricky, and if you do it properly only you can elicit it. So as I said, it should be done in quiet, awake or sleep state. Never perform in the when the child is crying. So when you release the baby from out and put it, the child will open his hand. This is the first step that will happen. First is opening of both hands, followed by, that will be second is extension and abduction of the arm, which will be followed by anterior flexion. This is not shown in this picture. I'm writing anterior flexion. What is this anterior flexion? Anterior flexion, embrace. He will embrace. One is like hugging you, kind of. It will hug himself. He embrace himself. So it is like hugging. So first, the child will open his both hand, followed by extension and abduction of the arm, and try to hug himself by anterior flexion. That is anterior flexion and adduction, and there will be a final fourth step is the child will cry. That is known as audible cry. These are the components. All these four components should be present. First, the child should open his both hand. There will be extension and abduction of the arm, followed by anterior flexion and adduction. It is known as embracing himself. And following audible cry. All these four components should be present. These are the components of. If anyone asks what are the components of Moro reflex, you should say all this. In few books, even the leg components are given, but I don't want to complicate the things. And arm and cry. These are the three you should tell. The leg component is also there, but that is complicated for you. So at least this four component must be told, and it develops start from 28 weeks. It matures at 37 weeks, mature as 35, and it disappears by 3 to 6 months. And what is the clinical relevance? This motor reflex is depressed in the case of birth asphyxia and asymmetric motor reflex. One side is absent, meaning what you suspect? You should suspect brachial nerve palsy. And another most important thing should be suspected is clavicular fracture. And sometimes this reflex is exaggerated in hypoglycemia. Hypoglycemia when the child has low glucose, right? Right. Right. Okay. So this reflex, breastfeeding reflex. So what are the breastfeeding reflex you will know for? So breastfeeding reflex or rooting reflex, sucking reflex, swallowing reflex. So with this, when I will discuss about the feeding the baby, so we'll see that. So normally in 28 weeks, nothing will be present. At 32 weeks, the rooting reflex starts. What is the rooting reflex? When you keep your hand over the angle, any one side of the angle of mouth, if you try to do that, the child will turn toward the direction where you kept your hand. This is the why, because by this way, the child can locate the nipple. It is for your locating your nipple. Rooting reflex, please write it. Rooting reflex helps in the location of locating the nipple. Right? Sucking reflex is normally absent. Sucking reflex helps in the to extract the milk from the breast. So the sucking will stop only when the entire teeth by forming what is the teeth? It is the areola nipple complex. Areola nipple complex get pressed gets pressed between the palate and the tongue of the baby, right? And then the child will suck the milk. It will take some few gulps of milk, store in his parents, and then he will swallow it. He or he will swallow it. Now, this swallowing should be coordinated. Suck, swallow, breathe. This should be coordinated. And this coordination is only seen at the age of 34 weeks. It will start to develop, but it matches by 37 weeks. Right? So this is the thing that is given in the initial choice of feeding, which I will discuss further. So this is the breastfeeding reflex. You will see it's rooting, sucking, swallowing, or the breastfeeding reflex. So hypothermia. So hypothermia is nothing but why neonates are prone. This is the important question. Important question. Important question. Please, please, please. See to it. Hypothermia neonates are prone because they lack what? Yes, they lack heat producing mechanism. One thing, they have large surface area to the body weight. They lack soft subcutaneous fat, right? And they have large amount of body water. They have minimum brown tissue, brown fat, and the skin are transparent. And as a result, they are more IVL. What are the mode of loss? Evaporation is by wait a minute. Evaporation. So the water over or the fluid over the body, right? That's why we have to dry the baby. That will get evaporated. So you have to dry the baby. The rational behind everything is not just because we have to read it. There is some reason why we have to dry the baby is because to prevent the heat loss because of evaporation. Conduction. What is conduction? To the surface where the child lies. So the heat loss by the surface over the baby lies. That's why you have to receive the baby in the radiant warmer so that the baby doesn't lose the radiant over the baby lies. Conversion to the air surrounding the child, the baby will lose the heat surrounding the baby. Hence, the delivery room temperature set 26 to 28 degrees Celsius and it should be free, drought free air. It should be free from drought free air. There must be no air. You have to off your fan, you have to off the AC, and delivery room, the newborn corner should be free from the drought air. So then you will prevent this convection. So what is radiation? Radiation means with the part which is not in contact, the child will lose the heat from the baby is not in contact. Radiation is your head. So loss of heat from the part which is not in contact with the surface. Mostly your head. So 70% of heat loss occurs via radiation. That is also from your head. Hence, you have to dry the egg completely before the body. So it should be dried first. So these are the four mechanisms by which the heat loss in occurs in neons. So why hypothermia is very important because what the hypothermia does to the brain. Once the child goes for hypothermia, there is a catecholamine release. Now this catecholamine release, what it do in the brown tissue, that is your brown fat, it will act on your beta oxidation and uncouples the beta oxidation from the your ATP formation. As a result, the heat generated is used for heating the blood, and that helps in prevention of hypothermia, prevent the fall in temperature. Right? So there also release of free fatty acid. So this is the way by how that catecholamine acts. But what effect that this process will do to the baby? Now, as I said, there's uncoupling of beta oxidation in brown fat. Each generated is used. Now, what happened to the beta oxidation? The product is your free fatty acid. Now, this free fatty acid will displace your bilirubin from the albumin and cause hyperbilirubin. Yeah. So first thing is, sorry, I'll use this. Okay. First thing is it cause hyperbilirubinemia, right? And then catecholamine will increase the metabolic rate, so the child will have more metabolism, more glucose will be utilized, there will be hypoglycemia. And also it increases the oxygen requirement. When more oxygen requirement, the child will go for hypoxemia. There will be lactic acidosis, the child will go for metabolic acidosis. On this metabolic acidosis and the catecholamine, both will cause persistent pulmonary hypertension and peripheral vasoconstriction. And the hypothermia itself will reduce the surfactant production. As a result, the child will go for respiratory distress. So all disorder complication and sign and sim clinical features. Same the clinical feature will be present in the hypothermia. So how to prevent it? Warm chain, delivery room temperature 26 to 28 degrees Celsius. As such, immediate drying, skin to skin contact. That is your KMC for all stable neonates of weight, low birth weight, 2 kg babies, more than 1.8 kg, radiant warmer, radiant warmer. Okay, breastfeeding, yes, you have to ensure. Bathing and weighing should be postponed for a preterm babies till the cord falls off. That most takes about 7 to 10 days. Appropriate plating, multiple layer of, the important thing, multiple layer of light clothes can be used rather than wool clothes. Do rooming in, very, very important, rooming in. Co-bedding with the mother, it will increase the bond. The last important thing which everyone fails to recognize is your warm transportation. Please roll, which is the weakest chain in the warm chain. If anyone asks, the answer should be your warm transportation. Weak chain. So this is the thing because from labor room to the NICU or SNCU, the child doesn't get the temperature. As a result, at this point, the child may suffer from the hypothermia, and all the consequences of hypothermia will be noted here. Getting it? Yes. So, what is the difference between radiant warmer and incubator? See, in the incubator, it's a closed loop. It's a closed loop, acrylic cabin, right? It's an open system, and the bassinet, the bassinet, the radiant warmer will provide heat. Got it? And here, the heat will be provided by the fan. You can see here, this, I will highlight it. So here, you see, this is the area. Here, there will be fan like this. This is the table. This is where the baby is lying here. So there will be a fan here. There will be a fan here. Okay. So what happened? The air circulates here, and now this is a warm air. So by the method called as convection. Okay, it's known as convection. The heat loss convection, but here the heat is given by the convection because the warm air circulates inside this uh, uh, bed, inside the bed, which provide the heat to the baby. This is the convection, and humidification can be done in the incubator, which cannot be done in your radiant warmer. Whereas uh, this is the one thing. And second thing, in approaching the baby to do some procedure is very easy in the radiant warmer, whereas in your incubator you cannot do. You have two port, right? This is a two port. You can see this. With this only you can approach the baby, and by keeping sanitization, when sterilizing, the radiant warmer is much easier compared to the radiant incubator. And most importantly, humidification can be done in your incubator, which is very, very important. So any baby who is less than 32 weeks and less than 1.5 kg, getting any baby who are less than 32 weeks and 1.5 kg, we go with incubator, not the radiant warmer. Cost high is your incubator, whereas low is your radiant warmer. This is the differences. So radiant warmer, a radiant heater installed over a basin provides heat. It's an open cat system, so access to the baby is easy. Whereas in incubator, circulation of warm air by an inbuilt heater and fan into a canopy, it's a closed system, whereas the child access to child is restricted. Insensible water loss is more in your radiant warmer, where it's lesser in incubator. That's the reason why it is more suitable for the 1.5 1500-gram babies or less than 32 weeks babies. Humidification can be done easily in your incubator. Maintenance and disposal is very easy in the radiant warmer, whereas incubator is difficult to maintain and disinfect. Cost is low of radiant warmer, and incubator is high. What is the treatment? So for mild hypothermia, which is cold stress, got it, which is 30, tell me, it's about 36.0 to 36.4 degrees Celsius. Remove from the source. Very important. Remove from the source. Pre-warmed linen or clothe the child. Skin to skin contact or radiant warmer. Simple. If it's a moderate, like case, you are 35.9 to 34 degrees Celsius, so 32 degrees Celsius. Severe is your 32 degrees Celsius. If in this case, both the case, remove from the source. One thing. Second thing is, and okay, you have to remove from the source, then put it on the radiant warmer. If it's a preterm baby, keep it on incubator. Yes, exactly. Third thing is you have to IV line assess, correct for shock by giving NS bolus, give IV dextrose, collect blood or B blood culture, and start empirical antibiotics. And what about the temperature management? Slow warm or fast warm till the child comes till 34 degrees Celsius. After 34 degrees Celsius, slow warm till you take the baby to the normal, right? So this is the treatment protocol for both your mild hypothermia and the moderate and severe hypothermia. So breastfeeding will be so I guess it's very lengthy. With neonatology itself a big topic. I am trying to adjust and cut shorting the things and telling you in a bit important way so that it will be easy for the revision as well as to understand the basic concept because neonatology is something which you will not learn in anywhere except in the pediatrics. That's the reason why I'm explaining in quite detail. So, by the way, I will be completing with breastfeeding, and the rest topic I will be doing in next week. Most probably, I will be doing in Wednesday, I guess, so that we will complete it before we going jumping to the nephrology. So, because if you have to go down around 2 hours, so I will be completing with breastfeeding. Then other topics which are present like care of low birth weight, feeding of low birth weight, respiratory distress, perinatal asphyxia, neonatal jaundice, hypoglycemia, and neonatal seizure. This I will be discussing in coming Wednesday. So we will discuss on Wednesday. So we will be completing it with breastfeeding. So this is a start topic for MBBS because you should know in and out of the breastfeeding, what is the benefit of breastfeeding, reflexes of breastfeeding, which we taught that mother, we deal with the baby, but we have to start with a composition of breastfeeding, positioning and lactating, issues with breastfeeding, both mothers and babies, and breast milk bank. So what we'll see this. Sorry, before we go to benefit of breastfeeding, what is the breastfeeding benefit? So normally you should know any baby who's been given breastfeeding, the 14-time reduction in diarrhea and 4-time reduction in pneumonia. And it is a cost-effective way to reduce neonatal mortality rate and your under 5 mortality rate. So the government of India is promoting this called as breastfeeding. This is very simplified way to prevent infection, to prevent complication, to prevent malnutrition. So breastfeeding is a must for the child. So as per the NFHS 5 best hour of life, around 41 to 45 percentage of baby are getting the milk, whereas 6 months of exclusive breastfeeding is given only 60 months. Still we are lacking. See, still we are 39% are not getting the exclusive breastfeeding. The first question is what is exclusive breastfeeding? Exclusive breastfeeding is the baby should receive only breast milk, either direct or expressed for first 6 months with exception of vitamin or medication when indicated. This must be your definition for This must be a definition for the topic. So exclusive breastfeeding is baby should receive only breast milk, either direct from the mother or should be expressed for the first 6 months with exception of vitamin D or medication when indicated. This is the definition. So what are the benefit of breastfeeding? This is the important 10 mark question. It was asked in your, I think, August or March 2022 in the Tamil Nadu MGR University as a 10 mark question. So, what are the benefits of breastfeeding newborns? It is the nutritional superiority. One thing, exactly. It is very easy to procure. It is given in the temperature, body temperature, which babies adapt without any sterilization. Don't need to do anything. So it's easy to procure. So this nutritional superiority compared to the cow milk and formula milk. One thing, carbohydrate is rich in lactose, which is very important for the lactobacillus development, and also easy to digest, and galactose, which is very, very useful from the galactose cerebrosalis, which you read in your biochemistry, which help for the brain development. Proteins is very less compared to your cow milk, okay, but we have more common of lact albumin and lact globulin. What is that? Lact globulin and lact albumin. Now this both are easy to digest, and also this all thing will produce very low solute load to the kidney, to baby's kidney. Hence, it is kidney friendly, renal friendly, and the renal friendly to the baby. Whereas the cow milks, if it is given we should, if you're giving a cow milk, it's also given non-diluted, but it has high solute load, which the kidney of the baby cannot tolerate and may have many problem in the kidneys of the child. Second one thing is protein we go for. Another thing is taurine and cysteine. This all helps in the brain development. About the fat, the two type of fat that are present in a PUFA helps in the myelination. Okay, PUFA helps in myelination, and some other fat is also omega 3 and omega 6 fatty acid helps in formation of prostaglandins and steroids, which are very important. Prostaglandin is important. Steroids important for your all your hormone, testosterone, aldosterone, cortisol formation. And this cow milk oligosaccharide is the only thing which is present in the breast milk, not in any other milk, will act as a prebiotics and helps in good gut bacteria formation and helps in the prevent allergy, prevent infection, prevent diarrhea. Vitamin, waters, minerals are more abundant compared to our cow milk, and two vitamins which are absent in breast milk, which has to be supplemented: vitamin K, which we give post birth, as we discussed while the routine care, and second is the vitamin D. Immunological superiority has many immunoactive substances like IgA, lactoferrin, immunoglobulins, iron, interferons, by okay, these are the things which are present as immunological, which is not present in the cow milk. And growth factors, which helps as a tropic factor for the intestinal epithelial cell development, villus development, helps in the absorption and also mental health. So these are the factors which are very benefit for the newborn. What of the mother? It causes involution of uterus, so it prevents postpartum hemorrhage, it prevents breast cancers, causes lactation amenorrhea, so it helps in the family planning also, it causes the weight loss, it increases bonding, and it also prevents the type 2 diabetes in the mother. So once we see the sucking, rooting, and swallowing reflex, which are the breastfeeding reflex in baby, what about the mother? We have two reflex which you should know. One is oxytocin reflex, and another is prolactin reflex, right? So what about the oxytocin? So what happened to oxytocin? Oxytocin is produced from your posterior pituitary. So whenever the baby sucks, see, so the breast is innervated by, sorry, this is oxytocin. The breast is innervated by what? Yes, now very, very, very nerve fibers. Now this nerve fibers, once the baby sucks, and the baby mother is having a positive, like think loving of baby, sounds and sight of baby, instills confidence, then this will start go to the posterior pituitary and produce oxytocin, and oxytocin releases act on the myoepithelial cells around your lactocytes and cause the secretion, not secretion, it contracts and will release of milk into lactoferrin 7 from the abdomen. So here the mother should have a positive mind. That she should be very happy. She should be relaxed. Then only oxytocin will be released. If she is worrying, if she has stress, if she has pain, if she doubt on herself, then it hinders the oxytocin release, and the breastfeeding will be impaired. So what about the prolactin reflex? So whenever the baby sucks, that will through the nerve fiber, it goes to the anterior pituitary and releases the prolactin. Now this prolactin will causes the production of milk. It is known as lactogenesis. It is known as lactogenesis, also galactopoiesis. It is lactogenesis and galactopoiesis. अब ऑक्सीटोसिन रिलीज में क्या करता है? What it does? It is known as galactokinesis. It causes the release let down reflex. Called as let down reflex. Galactokinesis or let down reflex. Right? Okay. Hmm. Okay. So galactopoiesis. So for a oxytocin reflex to work, the mother should start early feeding. That is the early initiation of feeding within 1 hour of life of the baby. The mother should go a frequent feeding and night feed. Early frequent night feed. If this is followed, then the oxytocin prolactin will be released. Sorry, I'm writing wrong. Okay. This um this prolactin reflex to work, the mother should start early feed, that is within 1 hour of life, the frequent feeding, and then the child must be night. So early, frequent, night. These three components should be present so that more prolactin will be produced. More prolactin will cause more milk production, so the mother will give adequate amount of milk to the baby. These are the two reflex that act in the mother for the production of the breast milk. And the breast milking reflex, which I already discussed, the rooting, sucking, swallowing, or the breastfeeding reflex that is noted in the neonates. So, how do you say that the mother breastfeeding is adequate? If after the breastfeeding, if the baby is satisfied, sleeps for 2 to 3 or 3 to 4 hours, passes urine 6 to 8 times per day, and that is a documented weight gain, and the transitional stool. I'm talking about breastfeeding from meconium, black color meconium to golden yellow stool. If everything is present, then you can say does the baby is adequate. What is about nipple confusion? So never give dummies pacifier bottle feeding. What happen in bottle feeding kind of condition? The baby take as a liberty to know how much amount the child has to drink. So it's a passive process. So whenever the baby thinks it will drink, because if a passively, when the child will keep in the mouth of the baby, the child starts sucking. Now the amount of milk is determined by the baby. If baby need more milk, he will furiously will drink that milk, and every milk goes in. Whereas if the baby doesn't need so much of milk, the child will drink slowly and it will take. It's a passive process, and this is very make the baby lazy. It causes a lazy baby. So what happened when you train the baby with the breast bottle feed? Now, when you keep the baby over the breast milk, breastfeeding, if you try to breastfeed, the child will not drink because breastfeeding is an active process. It's a kind of exercise, and baby doesn't like exercise because you are already expose the child to a passive feeding process called as passive feeding process like bottle feeding, which is very easy for him. He or she doesn't want to spend much energy in a bottle feeding because it's very easy. There is no much lot of energy is required to bottle feed because the baby can control how much she or he want to feed. Whereas in case of breastfeeding, it's a kind of active process that the child has to suck, swallow. All the breastfeeding reflex has to appear, which the child doesn't like after when he or she has been exposed to a very simple process like a bottle feeding. This lead to a condition called as nipple confusion. This is also an important question asked in your university. So, what is effective suckling? When you say the child sucks, when you can hear gulping, once the child takes that form a teeth within his mouth and start to suck, there will be a gulping sound and there will be fullness of the cheek. If everything is present, then it is known as effective suckling. This is the skill which we'll discuss in this class. So this with this 2 to 3 questions, we'll stop. Okay. What is positioning? What is the good positioning? This is the question. What is the sign of good lens? These are the two important questions which is asked, and you should also know it, right? Good positioning. Whole body of the baby should be supported. Exactly. Head and body, that is your trunk, must be in same line. Baby's abdomen and mother's abdomen should be touching each other. And the last thing is baby's nose at the level of nipple, right? Now, the next question is what is good latching? This is an important Viva question, your university question, and also your Viva question, university question, right? These are the two important thing on the so good latching is so what are the sign? One, the mouth should be wide open. Mouth of the baby should be wide open. The lip of the lower lip, mind it, the lower lip should be averted so that only the lower part of the nipple areola complex must be visible. Should be visible, and the chin must touch the breast. If everything is present, then it's sign of good latching. This is a sign of good position. Very important to be noted. So what are the problem in breastfeeding in the case of mother? What is one important? Inverted nipple. That's very important. Inverted nipple is one problem for which you use the injection technique, syringe technique to correct it. In sore nipple, what happen? As I said, the nipple areola complex must be formed within the mouth. The nipple area complex should go within the mouth to form teeth. To form TEAT, teeth. Like udder, cow का udder होता है ना? Like what you see udder of the cow. Like that form teeth. Then the child will suck it and swallow the milk. But what happened? In because of improper latching technique on latching technique, the only nipple get inside the mouth. What happened? Now child will try to suck it, but no milk will come. As a result, the child become furious. He start to he or she start to furiously suck. At the time, he or she may bite the nipple. This cause sore nipple. So here, what is the treatment? You have to clean it, or you have to put nipple. Sorry, if any cream medication is required, no, because of the improper technique followed by the mother. That is the reason. So proper latching and breastfeeding technique, latching positioning, and breastfeeding technique is itself a treatment for the for the mother, and she may apply iron milk for the over the lip. What about the breast engorgement or breast abscess? This is very breast engorgement as it's simple, similar. If because of inadequate technique or late initiation of breastfeeding, what happened? The milk is not ejected out. It start filled within the lobule and it become hard, tender, and warm. Now, if the mother expresses it regularly, frequent breastfeeding, correct latching will resolve it. And sometimes she can use hot fermentation for the same. But if she doesn't treat it, then it goes to the dangerous condition called breast abscess. Then she will have systemic signs and symptoms of inflammation like tenderness, severe tenderness, pain, fever, and also pus formation. Then here you have to go IND and antibiotics, right? What about not enough milk? Is this possible? Not enough milk, insufficient milk, is it that real? You have to hold on. If there is an adequate feed, if the child is sleeping after a feed 3 to 4 hours, he or she is passing 4 to 6 to 8 urine per day, adequate weight gain, and he or she is satisfied, then milk production is good. If that is not the case, then what are the causes of insufficient breast milk? One is delayed initiation of breast milk afterward. This is the most common cause of the uh, not enough milk. Then cracked or sore nipple, which I explained. Supplementary feed or prelactal feed. These are the two major culprits. Supplementary and prelactal feed, they are more major culprit. Infrequent nitrogen, as I said, for the production of prolactin, you should initiate breastfeeding early. More frequently, you have to breastfeed, and night feeding is very important. Unless you do a good night feeding or at least 2 or 3 feed, there will be no prolactin production. If no prolactin production, there will be no production of milk, and that may impact the milk production. There's breast engorgement, which I already discussed. Maternal stress, maternal illness or painless condition under sleep. It all will cause oxytocin release में problem करेगा. It will release the oxytocin release. When there is no oxytocin release, sorry, when there is no oxytocin per se release, there is no myoepithelial contraction. When there is no myoepithelial contraction, there is no let down reflex. When there is no let down reflex, the milk cannot be ejected out and the baby cannot pass. So for maternal stress, illness or painful condition, less sleep, where the oxytocin is get impairing, as a result, the let down reflex get impaired. As a result, the not enough milk condition affect. The last thing is what about the breast milk bank? So breast milk bank or facility-based lactation, pasteurized donor human milk is in. So here what happened? The mother, some babies, mother is very sick who cannot give milk, or the mother has been expired because of a severe illness. Then these babies need some milk. So for them, instead of going to formula feed, in India, in several hospitals, they have started the mother milk bank or breast milk bank, where the donor human milk is taken, which is screened. Donor milk is collected, then we process it, then pooling, that is pasteurization. What is this pasteurization? Pasteurization, where we do the sterilization of milk with the help of the known method called as Older's method. In Older's method, we use the temperature around 62.5 degrees Celsius over 30 minutes. Then do a testing for DH, donor's milk, for any serological testing, any bacterial contamination or there or not. If everything is passed, if everything is okay, then we store the milk and then we dispense the milk to the NICU, the needed babies. The point is, this PDHM retains most micro and macronutrition which is present in your normal breast fresh milk. But the only thing is, it lacks the immunocompetent substance of fresh milk. What I said, serum lactoferrin, IgA, immunoglobulin, interferon, which are normally immunoactive substance which are present in your fresh human milk. It's not going to be present here. As it is, this is one of some disadvantage, but it is more inferior to mom but superior to the formula feed. And the first human milk bank was started in Mumbai by the NGO called as NEA in the year of 1989. So with this, we will complete today's session. So today we discussed the important topic, mainly NRP 2020, which I needed. I That is a major chunk of your neonatology, which you should need in and out for a exam purpose, practical purpose, and also as a doctor you should know neither, and then which the essential newborn care, what are the initial examination, what are the way you will care for the child, and then what are the routine other things you will do. And we did talked about the hypothermia concept, temperature management, and also about the breastfeeding. Next session, which I will mostly take in the Wednesday, we will discuss about the low birth weight preterm babies, care of the preterm, and then we go for the disease specific like respiratory distress syndromes, and then perinatal birth asphyxia, neonatal seizures, sepsis, and hypoglycemia, and finally we complete with the jaundice. Wednesday we will be completing it. Okay. Okay. So with this, I will close the class. Uh, yep. I guess we'll close the session right now. Raghu, hello,
Thanks,
hello.
thanks, sir. Thanks, sir. And I hope
Okay.
if any doubts are there, you can put it in the chat box.
Yeah, chat box or in the Medusane group also you can share. In next class, we will be conducting on Wednesday, Raghu, about the remaining
Okay, sir.
neonatology. I
Okay.
will complete in Wednesday
It's
because
too
it's
much.
offer too much.
Eight
Yeah, yeah, it's very too much. It will be very lengthy, so that I completed most of the chunk because the NRP was very important for the UG and exam questions are also asked. Recent changes have been developed, so I likely these questions will be asked in your university paper also in your practical. That is the reason I took nearly 1 hour to explain the NRP. Rest topic are very simple. In Wednesday, I will be completing mostly by 1.5 hour. I will be completing in the rest topic. It's not that much tough for undergraduate, but for the sake of undergraduate exam and the importance, I took the NRP in bit detail. Okay, I guess everyone got some important points and it helped you in clearing your some doubts. If any doubts, you are always welcome in WhatsApp in the Medusane group. I am there to help and hope it will help you. It will gear up your exam preparation. Thank you. Okay,
Thank you, sir. Thank you, sir.
okay, bye.